Welcome to the deep dive. Today, we're unlocking a surprisingly common piece of the human puzzle, prolactinomas. These are benign pituitary tumors, often overlooked, but they can have a bigger impact than you might think.
Exactly. We're diving into our prolactinoma detailed notes today
Yeah.
to really pull out the crucial insights. Our mission for you, the listener, is pretty straightforward. To
Mhm.
understand what prolactinomas are, why they happen, their effects, which can be quite different for women and men, interestingly, plus how they're diagnosed and the treatments.
Right, and we want to do that without getting bogged down in super dense medical jargon.
Absolutely. The goal is for you to feel well-informed, maybe even pick up a few surprising facts along the way.
Okay, let's unpack this then. What exactly is a prolactinoma?
So at its core, it's a benign, meaning non-cancerous tumor. It grows from cells in the pituitary gland.
Mm-hmm.
And its main characteristic, the defining thing, is that it overproduces the hormone prolactin.
And the pituitary gland, that's like the body's main hormone control center, isn't it? Sending out signals for all sorts of things.
That's a great way to put it. Yeah, it's like a central command dispatching these hormone messengers. Prolactin is just one of those messengers made by specific cells called lactotrophs in the front part of the pituitary.
Okay, and what's prolactin's usual job in this whole system?
Well, its primary role is stimulating milk production, after childbirth especially, but it also plays a part in reproduction generally and can influence some behaviors too.
Interesting.
Now, these prolactinomas, they get classified by size. A microprolactinoma is small, less than 10 millimeters across.
Tiny.
Yeah, really small. And then a macroprolactinoma is 10 millimeters or bigger. And that size difference, even though it sounds small, can actually lead to pretty different symptoms.
So a tiny difference on an MRI scan can mean someone feels completely different.
Yeah, yeah.
Right. That's really interesting. How common are we talking here?
They're actually the most common type of pituitary tumor that produces hormones. Something like 40% of all pituitary adenomas. But what's really striking is who gets them. They're much, much more common in women, particularly during their reproductive years. But they're pretty rare in children. It's almost like two different patterns of occurrence.
Hmm. Okay, so benign tumors, pituitary gland, too much prolactin. But why? What's actually going wrong, mechanistically speaking?
Right. So normally, prolactin release is kept in check, tightly regulated, by dopamine.
The brain chemical.
Exactly. Dopamine produced in the hypothalamus, which sits just above the pituitary, acts like a brake. It tells the pituitary cells, okay, stop making so much prolactin.
Gotcha.
But with prolactinomas, the tumor cells, well, they essentially become less sensitive to dopamine. They sort of ignore those stop signals.
So the brake pedal isn't working properly on those specific cells.
That's a good analogy, yeah. It gets jammed in the off position so they just keep turning out prolactin. And then there's the growth aspect. As these tumors get bigger, especially the macro ones, they can start pressing on things nearby, like the optic chiasm, that's where the optic nerves cross, crucial for vision,
Hmm.
or even just the normal pituitary tissue itself, which can mess up the production of other important hormones.
Okay, that makes sense. So is there usually a specific trigger? Why do these things just pop up?
Well, in most cases, the honest answer is we don't know the exact trigger. It's usually what we call a sporadic pituitary adenoma, a one-off event in the gland.
So bad luck, basically.
Sort of, yeah. Now, there are some rare genetic links. Conditions like MEN1, multiple endocrine neoplasia type 1, and FIPA, familial isolated pituitary adenoma, but these account for a really small fraction of cases.
So most people with a prolactinoma don't have one of these genetic conditions.
Correct. It's much more likely to be sporadic. But, studying those rare familial forms does give researchers clues about how pituitary tumors might develop in general.
Right. But the notes also stress something important. You can have high prolactin levels for reasons other than a prolactinoma. That seems crucial for diagnosis.
Absolutely critical. We need to distinguish hyperprolactinemia, just the state of having high prolactin from actually having a tumor causing it. There are physiological, totally normal reasons for hyperprolactin.
Like pregnancy.
Exactly. Pregnancy, breastfeeding, those are expected times for hyperprolactin. But even things like significant physical or emotional stress or really intense exercise can temporarily bump up the levels.
Ah, okay. So a single high reading on a blood test isn't automatically a tumor alarm bell.
Definitely not. And then there are medications. This is the big one. Certain drugs can raise prolactin levels and mimic prolactinoma symptoms.
Which ones?
Some antipsychotics, like risperidone is a common example. Certain antidepressants, metoclopramide, which is used for nausea, even opioids. So reviewing someone's medication list is like step one.
Makes sense.
And then there are other medical conditions. Low thyroid function hypothyroidism that can do it. Chronic kidney disease too. Even PCOS, polycystic ovary syndrome, has links. And finally, anything that physically interferes with dopamine getting from the hypothalamus down to the pituitary can cause prolactin to rise, like pressure on the pituitary stalk from a different kind of pituitary tumor or another growth nearby.
So, lots of potential culprits. It really underlines why a careful diagnosis is needed.
Precisely. You can't just jump to conclusions based on one prolactin level.
Okay, this complexity leads us nicely into the symptoms. The notes highlight differences between men and women, which you mentioned. Why is that?
It mostly comes down to prolactin's effects on the reproductive system and the hormones controlling it. In women, high prolactin often messes with the menstrual cycle pretty directly.
How so?
You might see irregular periods, that's oligomenorrhea, or period stopping altogether, which is amenorrhea, because it often suppresses ovulation. Infertility can be a major presenting issue.
Right.
And then there's galactorrhea that's producing breast milk when not pregnant or nursing. That can happen too. These symptoms are often noticeable enough that women tend to seek medical advice relatively early.
That makes sense, yeah. Things like period stopping or unexpected milk production are hard to ignore. What about in men? The notes suggested it can be a bit more subtle.
That's often the case. In men, hyperlactin tends to lower testosterone levels. So the symptoms can be things like erectile dysfunction or decreased libido, lower sex drive.
Things that might be blamed on stress or getting older.
Exactly. Also infertility due to low sperm count linked to that lower testosterone. Less commonly, men might get breast enlargement, gynecomastia, or very rarely, galactorrhea. Because these symptoms can creep up more gradually or seem less specific, men sometimes don't seek help quite as quickly.
Right. And then layered on top of those hormonal effects, you have symptoms from the tumor size itself, especially the macroprolactinomas.
Yes, the mass effect symptoms. When the tumor gets large enough to press on things, persistent headaches are common, just from increased pressure inside the skull.
Okay.
And a really key sign, if it's pressing on the optic chiasm, is a specific type of vision loss. It's called bitemporal hemianopia.
That sounds technical. What does it mean?
It means losing vision on the outer sides of your visual field, in both eyes. Sort of like having blinders on. Your central vision might be fine, but the peripheral vision goes. That pattern is a major red flag for pituitary lesions near the optic chiasm.
Wow. So that specific vision issue plus headaches would strongly suggest a larger tumor.
It would definitely push it high up the list of possibilities, yes.
Yeah.
Very rarely, large tumors can affect other cranial nerves too, causing other neurological problems. And as I mentioned, they can squash the normal pituitary, leading to deficiencies in other hormones, a state called hypopituitarism.
So a whole range of potential issues. Okay, someone has some of these symptoms. How do doctors actually figure out, yes, this is a prolactinoma? What's the diagnostic process?
It usually kicks off with blood tests. Measuring the serum prolactin level is the first step.
And you mentioned the level itself gives clues.
It does. Mild elevations, say under 100 nanograms per milliliter, NGML, could be due to medications, stress, hypothyroidism, lots of things. But markedly high levels, generally over 150 or 200 NGML, really point towards a prolactinoma.
And the really big ones.
With macroprolactinomas, the levels are often much higher, frequently over 250 NGML, sometimes way higher. But again, one slightly elevated reading needs context, repeat testing, considering other factors, it's all important.
So the degree of elevation is a strong hint, but not the whole story.
Not the whole story. Doctors will usually check other hormones too to get the full picture. Thyroid function TSH is crucial to rule out hypothyroidism.
Right.
Then reproductive hormones, LH, FSH, and testosterone in men or estradiol in women. This helps see the impact the hyperlactin is having. Sometimes, if other symptoms suggest it, they might check IGF-1 to screen for acromegaly, which is caused by excess growth hormone, another pituitary issue.
Okay, blood tests paint part of the picture. Then I assume you need to actually see the pituitary.
Exactly. Imaging is key. MRI, magnetic resonance, imaging of the pituitary gland is the gold standard.
Why MRI specifically?
It's just very good at showing soft tissues and fine details in the brain. They often use a contrast agent, gadolinium, injected during the scan. This makes the tumor stand out more clearly from the normal pituitary tissue, even if it's quite small. The MRI lets doctors see the exact size, location, and whether it's pushing on anything important, like the optic chiasm, or invading nearby areas like the cavernous sinus.
What if someone can't have an MRI? Like if they have certain metal implants?
Good question. In that case, a CT scan computed tomography of the pituitary is an alternative. It's generally less sensitive than MRI, especially for the microprolactinomas, but it can still provide useful information.
And what about that vision test you mentioned earlier?
Visual field testing, yeah. That's essential if the patient reports any vision changes or if the MRI shows the tumor is close to the optic chiasm. It carefully maps out their peripheral vision to detect that characteristic bitemporal hemianopia pattern or other deficits.
Okay. And one more thing, pregnancy test.
Absolutely. For any woman presenting with menstrual changes or galactorrhea, ruling out pregnancy first is standard procedure.
Right. Makes perfect sense. Okay, so the diagnosis is made. We know it's a prolactinoma. What's the plan? What's in the treatment toolkit?
The main treatment, and usually the first line, is medication, specifically drugs called dopamine agonists.
Ah, connecting back to the dopamine break idea.
Exactly. These drugs basically mimic dopamine's action on the tumor cells. They bind to the dopamine receptors on those cells and tell them to stop overproducing prolactin. And importantly, they often shrink the tumor, too.
Which drugs are used?
The preferred one nowadays is usually cabergoline. It tends to be more effective, lasts longer, so you don't have to take it as often, maybe just once or twice a week, and generally has fewer side effects.
Okay.
An older option is bromocriptine. It still works, but often needs daily dosing, sometimes multiple times a day, and it's more likely to cause side effects like nausea or dizziness. But it's still used, sometimes for specific reasons, like during pregnancy planning.
So the goal is lower prolactin, shrink the tumor. How do you know if it's working?
Regular monitoring. Blood tests to check prolactin levels, usually every few months initially, then maybe less often once stable. Repeat MRI scans might be done maybe after 6-12 months of treatment, especially for macroprolactinomas to see if the tumor has shrunk. Or sooner if symptoms aren't improving or are getting worse.
These drugs sound pretty effective. Is medication usually enough? Or is surgery common?
For most people, especially with microprolactinomas, medication is highly effective and might be the only treatment needed. Surgery comes into play in specific
Oh,
situations.
such as?
Well, if the drugs don't work well enough, if prolactin levels stay high, or the tumor doesn't shrink significantly, or if someone just can't tolerate the side effects of a medication, even at low doses. A more urgent reason for surgery is sudden, severe vision loss from a large tumor pressing on the optic structures. Surgery can relieve that pressure quickly. And sometimes, rarely, if a tumor shrinks dramatically with medication, it can cause a leak of cerebrospinal the fluid around the brain, which might need surgical repair.
How do they actually do the surgery? Through the skull?
No, usually not. The standard approach is called transsphenoidal surgery. They go through the nose and the sphenoid sinus at the back of the nasal cavity to reach the pituitary gland.
Wow, through the nose.
Yep. It could be done using either a tiny camera on a thin tube that's endoscopic surgery or using a microscope. It avoids needing to open the skull. Success rates are pretty good, especially for microprolactinomas, maybe around 90% cure rate. For macroprolactinomas, it's a bit lower, closer to 50% because they can be harder to remove completely.
Okay. And radiation therapy was also mentioned. Where does that fit in?
Radiation is more of a backup plan. It's generally reserved for tumors that don't respond well to medication and persist or come back after surgery, or sometimes for unusually aggressive tumors.
What kind of radiation?
There are a couple of main types. Stereotactic radiosurgery, like gamma knife, uses many small, highly focused beams of radiation that converge precisely on the tumor in a single session. Another option is fractionated radiotherapy, which delivers smaller doses over several weeks.
Are there downsides to radiation?
Yes, there can be. The main risk is damage to the surrounding normal pituitary tissue, which can lead to deficiencies in other hormones over time, sometimes years later. There's also a small risk of damage to the optic nerves if the tumor is close by, so it's used carefully.
Right, a last resort kind of thing. What about pregnancy? You mentioned bromocriptine. How is a prolactinoma managed if someone wants to conceive or becomes pregnant?
It's a really important area. For women with microprolactinomas, the risk of the tumor growing significantly during pregnancy is quite low. So often, the dopamine agonist is stopped once pregnancy is confirmed. With macroprolactinomas, the risk of growth is higher, maybe 15–30%. So these women need closer monitoring during pregnancy, including regular visual field tests. If significant growth occurs, or symptoms like bad headaches or vision changes develop, then treatment might need to be restarted.
And that's where bromocriptine comes in.
Yes, historically, bromocriptine has been preferred if medication is needed during pregnancy, simply because we have more long-term safety data on its use in pregnant women compared to cabergoline. Though cabergoline is sometimes used cautiously too, it's definitely a discussion to have with an endocrinologist and obstetrician.
So careful planning and monitoring are key there. Overall, then, what's the outlook? What's the prognosis for someone diagnosed with this?
Generally, the prognosis is very good, especially for microprolactinomas. With medication, most people can get their prolactin levels under control, symptoms improve, and they can live normal lives. Some might even be able to eventually stop medication if the tumor shrinks significantly or becomes inactive, though that needs careful monitoring.
And for the larger ones?
For macroprolactinomas, long-term treatment is often needed. The chance of the tumor coming back if medication is stopped is higher. But even then, with consistent treatment and follow-up, most people manage very well. It's usually a highly treatable condition.
That's really positive. Are there any potential long-term issues or complications people should be aware of?
Well, if a large tumor isn't treated effectively, the main risk is permanent vision loss from ongoing pressure on the optic nerves. There's also a rare but serious complication called pituitary apoplexy. That's sudden bleeding into the tumor, causing severe headache, vision loss, and hormone problems. It's a medical emergency,
Okay.
and treatment itself can have potential long-term effects. We mentioned the small risk of heart valve issues with high-dose cabergoline, though it's rare at the doses typically used for prolactinomas. And surgery or radiation can, unfortunately, sometimes damage the normal pituitary function, leading to the need for lifelong hormone replacement for other pituitary hormones like thyroid, cortisol, or sex hormones.
So follow-up care remains important even after successful treatment.
Absolutely essential. Regular blood tests to check prolactin levels are standard. Repeat MRIs might be needed periodically, especially if symptoms recur or prolactin levels rise. And for anyone who's had long-term low estrogen or testosterone due to the prolactinoma, monitoring bone density with DEXA scans is important to check for osteoporosis.
This has been incredibly thorough. Thanks for breaking it all down. So just to wrap up, what are the main things you really want our listener to take away from this deep dive?
I think the key points are prolactinomas are common, they are benign, not cancerous, and they cause high prolactin levels. They can affect men and women differently, especially regarding reproductive health. But the really good news is they are usually very treatable, primarily with medication. These dopamine agonists are often highly effective.
And early diagnosis helps prevent those more serious complications like vision loss.
Exactly. So if you, the listener, recognize any of the symptoms we've talked about, menstrual changes, unexpected milk production, decreased libido, vision problems, persistent headaches, it's definitely worth discussing with your doctor.
Yeah, definitely don't ignore those signs. It sounds like effective help is available.
Precisely. There are good ways to manage this and maintain good health.
So perhaps as you go about your day, you might find yourself thinking about that intricate dance of hormones in the body, how a tiny gland like the pituitary and a shift in just one hormone like prolactin can have such wide-ranging effects. Maybe it even sparks some curiosity to look more into that fascinating link between the brain and our endocrine system. Thanks for joining us for this deep dive.